Welcome to another webinar from the Steps Forward Innovation Academy. Today's topic is reducing barriers to physician PTO. Please note this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult with a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA.
Hi, everyone. Thank you for joining us today for this webinar on reducing barriers to physician PTO. As Alec mentioned, this is something that Dr. Brown and I, as well as our colleague, Dr. Diane Shannon, who is also an internist, has been working on for quite some time. And we have developed a toolkit, a new Steps Forward toolkit on how to do this, how to reduce barriers for taking time off and creating what we have coined as the term real PTO for physicians. So this webinar today will focus on the contents of this toolkit, which was just newly hot off the press, just published, available on our website, stepsforward.org. We'll send out a link as well. And it goes through practical, concrete tactics that practices and organizations can take to help physicians take their well-deserved time off. Okay, so let's talk about the PTO problem for physicians. And in particular, why is this problem for clinicians and physicians different than the rest of the world and the rest of the professional population? And that's mostly, I would say, these top two bullets here. Number one, of course, clinical coverage responsibilities, including EHR inbox coverage, particularly for ambulatory-based physicians. So, of course, when doctors go on vacation, patients don't stop getting sick, and the work needs to continue, right? There will be continuous work to be done that needs to be covered somehow by colleagues. And then the second point, which I think is perhaps the bigger issue, is this culture of self-sacrifice and 24/7 availability that is just so embedded in medicine as a field and as a calling. I mean, we all knew and expected to some degree when we chose the field of medicine that there would be an element of self-sacrifice and being accessible outside, the typical 9-to-5 work hours for the sake of helping our patients, for healing patients. That's why we went into the field. That's what we're passionate about. The problem is, of course, that when it's taken to an extreme and doctors are expected to be available literally 24/7 and have zero time to disconnect and spend for ourselves or with our families, then of course that becomes harmful, right? That does not benefit ourselves and it doesn't benefit our patients. The last two bullet points, I would say, are a little bit more universal to probably everyone who works a job, but the workload upon return and the guilt about burdening colleagues when we return, during our time off, really does create a barrier to taking time off, because we just don't want to face that, right? So, why take the time off? It's not worth it if we just have to come back to this mountain of work when we get back and our colleagues are all annoyed at us. Okay, so backing up just a little bit, let's talk about what PTO really is. So if you ask a colleague or ask a friend what PTO means to them, you may get responses such as pretend time off, partial time off, etc. Right? So that is kind of the crux of the problem here, is that physicians don't feel like they have true time off. Now, if you ask HR, you get a little bit of a different definition. So they will say that PTO includes these types of days off, right? So we have vacation, sick days, personal days, CNE, holidays. And then there's kind of the longer types of leave, which include parental leave, medical leave, and disability. Now, for the purposes of this webinar, as well as the toolkit that we wrote, we are focusing mostly on this top section. So these 5 types of PTO, which are the short-term PTO types. And that is because they apply to all physicians or all clinicians. And then also, because the bottom ones here, the parental leave and medical leave, the longer term leaves typically do involve different compensation policies, as well as they have different coverage policies in place from the HR standpoint. So we are not going to get into those as much because they can be a little bit more complex. And then one more note that I will mention is that sometimes the terms PTO and vacation are used interchangeably. You'll see that kind of in papers and news articles, et cetera, but they are technically different. As you can see, vacation is just a small subset of PTO. So vacation days and PTO days are not going to equal the same numbers. It's not going to be at the same denominator. So just to keep that in mind, vacation days, if you get 3 or 4 weeks, it'll be 15 or 20 days. But then if you include all PTO days, that'll be more. So that'll typically be 25 to 35 days. So just to keep that in mind, whenever you're talking about this, make sure you're comparing apples to apples. And even today, I may end up using the terms interchangeably, but they're not technically the same thing. So just want to make that clear to you all. Okay. So let's talk about what we feel real PTO should be and what it should mean. So we coined this term when writing this toolkit to include 3 components. And those are, number 1, patient care and EHR responsibilities are completely covered. Number 2, lead-in and catch-up time are planned. And number 3, that there is no negative impact on compensation. So this, in our mind, are the 3 fundamental components that should apply to all physicians when they are taking time off. And of course, the $1 million question is, how do we get there? How do we get from pretend time off, which is the reality right now for most physicians, to real PTO? And we outlined these 7 strategies or 7 steps in the toolkit, which I will spend the next 20 minutes or so talking about. So they are, number 1, embrace the 3 components, which we just talked about, of real PTO. Number 2, understand the business case for real PTO. Number 3, normalize the culture of taking time off. Number 4, provide adequate coverage of clinical responsibilities, including EHR inbox coverage. Number 5, enact reasonable on and off-ramp policies for taking time off. Number 6, design compensation model to adequately include time off. And then number 7, track time off to ensure fairness. Okay, so again, we kind of talked about 3 components already, so let's dive into the business case. So why should organizations care? Why should employers care about how much vacation their physicians are taking? Well, the short answer is it is linked to burnout, which is linked to turnover and intent to leave, so it directly affects the bottom line. And this has always kind of made sense on an intuitive level, right? On a logical level. If physicians are not taking time off, if they're not going on vacations, sure, they're probably going to be more burnt out, right? But what's exciting is that we now have data to support this. And this study was published earlier this year in JAMA Network Open by Dr. Christine Sinsky, who's our colleague at the AMA, and her co-authors. They looked at a cross-sectional study of over 3,000 physicians in the United States and found that over 70% of them worked while on vacation. And those who spent 30 minutes a day or more working while on vacation had a higher risk of burnout. So again, working on vacation is directly linked to burnout. The good news is that the flip side was also true. So those who took more than 3 weeks of vacation per year actually had a lower risk of burnout. So that's the hopeful side of the situation, right? Is if you encourage your physicians to take more vacation and they actually do take it, then that lowers the risk of burnout, which then of course helps with turnover and helps with reducing costs related to that. So I consider this kind of a landmark paper because it really showed what we all thought to be true, but it puts it, it gives it this quantitative value. And it's been, this paper has been highly read and highly cited and highly quoted in news articles. So people are really, this issue is important to people. It's really striking a chord with people, which we're really happy to see. and hopefully we can work towards offering more actionable solutions. Okay, so just a little bit more in terms of the business case. So, I just talked about the reducing burnout and turnover, but I also want to touch on the second reason, which are kind of not the hard costs, but the soft costs, are just that the trust component, right? If you're not going to give your physicians adequate time off, you will lose trust, you lose loyalty. And that, of course, is also linked somewhat to leaving the organization and turnover. Of course, that's harder to measure, but that's just another second component of all this, which should not be ignored. And when we talk to physicians from all over the country in writing up this toolkit, we heard quote after quote after quote about how it just makes them angry that they don't have time off, that they don't have adequate vacation coverage, that's why people are leaving the organization. So let me turn it over to Dr. Brown a little bit to discuss, to go back to number one and discuss a little bit more about how to calculate these hard costs of turnover.
Great. Thank you, Dr. Jen. Pleasure to be here, and thanks for joining us. So all of this Steps Forward toolkits, which are open access and free to all, many of them have an interactive calculator, including this one. So you can put in your own number of physicians in your organization. You can enter the rate of physician burnout. Here it's the average in the country, 63%. And then look at your individual organization and see what your current physician turnover rate is. Now, to calculate the impact on the bottom line, we've really used a very low estimate of the cost of turnover. We know that it can be 500 to 1.5 million, or 2 to 3 times the salary. So if this is a typical case, and these are the numbers that you've entered, this is an example, but you can put in your own numbers. If 14 physicians leave the organization due to burnout, part of the reason because they don't have, out of 365 days, even one 24-hour period where they can focus on non-medicine issues, the impact, the estimated cost of that physician turnover can be almost $7 million. And again, that is based on the low estimate of $500,000 to replace a physician, and that includes vacancy, recruitment, and ramp-up time, which can be anywhere from 1 to 2 years. That doesn't even calculate the excessive cost when we lose one physician who's been caring for complicated patients, and then a new physician needs to order more tests, schedule more time to understand the complexity and develop a relationship with those patients. Now, if you have the resources and the budget and you effectively make that business case, and here's a generous $1 million cost of an intervention per year, and your projected reduction in burnout leads to the turnover rate being lower at less than 5%, there you can calculate the ROI, and that'll be very individual to an organization. So we want you not only to take this toolkit, and those on the who are listening in and tuning in, we hope that you understand the impact. That's why you're taking the time today with us. But how do you bring that back to your organization to help change the culture and get the resources and look at this from a business case? And I'll hand it back to you, Dr. Jen.
Thank you, Dr. Brown. Very well said. All right, so let's move on away from the numbers to this more nebulous and perhaps more challenging piece of the culture. How do we normalize the culture of taking time off? And again, I think in my mind, this is the most difficult part of it all, because that culture starts from early on in training, right? As medical students, as we go through residency and fellowship, and even as early career physicians, there is just the culture of the grind of working 24/7, no limit on work hours, you're always available. And that is part of the culture of medical training, along with the idea that the harder you work, the more you'll be, the more positively you'll be viewed by, your superiors and the higher ups. You get kind of this praise for doing that. So I think that is just sometimes very hard to undo as you transition out of training into the workforce. And so that's something that we have to really actively work to reverse. So how do we do this? So a few things that we kind of came up with that will work. So number one, ensure that leaders model taking time off themselves. So if you are a leader, and that could be, a group leader, a site leader, a medical director, all the way up to the CMO, when you go on vacation, you should let everyone know you are taking vacation and not check your email and not respond to emails, not send emails. Have the self-discipline to actually model what taking time off looks like for those people who may be looking up to you. The second bullet point is related, is just incorporate respect for time off into the professional etiquette. So it should be something that, is just is normalized. When someone is on vacation, you don't expect them to be checking email. You don't email them. It should be, if you need to let them know about something and you want to get it off of your to-do list, just schedule the send, delay the send till later, till when you know they are back. That should be kind of your responsibility as part of, again, this whole professional etiquette, that you should respect the time off of your colleagues and take it upon yourself to, delay communication or not send communication or resolve things without them while they're gone. People in other countries outside the US are much better about this than us, but it should just be, again, something that is expected as part of not just medicine, but any profession, honestly, but as part of the professional etiquette. This third bullet point I touched on, don't praise working while off. So if you hear about a colleague who came back from vacation and they were saying, oh, they brought their laptop with them to the beach and was checking their inbox, every day while they were gone. Sometimes the kind of knee-jerk automatic reaction is like, wow, that's so impressive that you did that. You must really care about your patients. And that kind of praise is counterproductive, right? It ultimately, your response should be, that's a problem, right? You should not have had to do that. I'm sorry you had to do that. What can we do to fix it? Because this kind of inadvertent praise we give to people, again, gives kind of the subtle encouragement, and especially for those in training or those earlier career physicians who are always kind of looking for that approval, that ultimately can become very detrimental to their future risk of burnout and joy in practice. So that's so moving on. So PTO policies, make PTO policies transparent and easily accessible. This one I kind of view as kind of lower hanging fruit. And that's just from the policy standpoint. Don't make it difficult. Don't make your physicians have to jump through hoops, like HR hoops, to find out what the PTO policy actually is, how many days they have, how many CME days they have, how much CME funds they have. If you make it very difficult to access that information, that sends the message that you don't actually want your physicians to be taking vacation. So these policies should be transparent, not only at the time of onboarding, but regularly throughout the year, like quarterly. They should just be kind of emailed out, or it should be a way to make it for physicians to easily access what their remaining balance is on their PTO. The next one, proactively block off PTO time into the physician template. This is actually something that's pretty, low-hanging fruit as well. So just as holidays, national holidays are automatically blocked off for ambulatory physicians, at least, into their template, the same can and should be done for PTO time. So if you have 4 weeks of PTO every year, those 4 weeks should be blocked off well in advance, at least a year in advance, into the physician template. There are some weeks that you probably know already will be weeks you'll be off, such as spring break for school or fall break, or there's certain weeks that are probably pretty set. Other weeks, even if they're not set, that's okay. Just block them off and it can be switched. They're not frozen forever, but it can be switched in the future. And it is much easier when it comes to patient rescheduling to switch them from 1 week to another, as opposed to not having any time on your template and trying to, and if you decide to take vacation later, you have to try to then squeeze those patients into additional into time slots that aren't there. So yes, this proactive blocking off of PTO time has been some practices that we've talked to has done this, and it's been effective as a way to encourage taking time off. The next one, engage individual physicians and working unit leaders for feedback and brainstorming, is speaking to the idea that, of course, every department, every work unit, every specialty, whether it's inpatient versus outpatient, of course, has very, very different needs for PTO and very different things that will work for them in terms of what will be a good solution and what's a practical solution. So it's really important to have these individualized listening sessions, brainstorming sessions, and really have a diversity mindset when it comes to coming up with solutions. And then finally, last but not least, celebrate time away. So, whether it's at a team meeting or some other kind of gathering, just if a physician has been on a CME conference or took a vacation with their family, have them speak for a few minutes about what they did. If it was CME, some key learnings that they took away from that, whether or not they recommend the meeting for others. Again, we've talked to practices that have done this, and it's been really effective in just getting people to accept that time off is a good thing, and it should be something that everyone does and feels good about and not guilty about. Okay, moving on. Provide adequate coverage of clinical responsibilities. So, of course, this is also something that can get very complex. It will vary widely depending on your practice setting. I am an outpatient-based physician, of course, so this is kind of more outpatient-focused, this section of the toolkit. But in terms of the coverage models, and in particular, how to deal with the EHR in-basket, the inbox coverage while away, that is a huge challenge, right? And that is a huge barrier when there is no adequate EHR inbox coverage for physicians to take time off, because they just do not want to deal with their inbox when they return, and they do not want to burden their colleagues with covering their inbox while they're away. So there are many different potential coverage models that are in existence that work, depending on your finances, your budget, the culture of the practice, et cetera. And Dr. Brown will speak about those in a minute. But my bottom line that I want to mention up front is that whatever model you choose, this should be the responsibility of the organization. It should not be a burden that falls upon the individual taking time off, because if it is, then they're not going to take time off. And, I have talked to many physicians who have said this exact thing, that they just don't take the vacation, or they'll just cover themselves and bring their laptop with them on vacation simply because they don't want to deal with finding their own coverage. Okay, Dr. Brown.
Thanks, Dr. Jen. So we'll probably have a robust discussion in the Q&A that follows this. But just to introduce that there are really many levels of coverage. The overarching message here is that we shouldn't think of it as our inbox, the physician, Dr. Jin's inbox, Dr. Brown's inbox as internists. It is the practice's inbox. So here at the very bottom, there's no designated coverage or agreement, and the physician covers their own EHR while away. They're checking the inbox while they're on vacation, and they don't feel, the pros is they don't feel guilty about burdening their colleagues, but the physicians can't disconnect while away. And just think about the burden on that physician to never have a break, 365, 24/7, but the impact on their partners, their family is huge. So these are 4 levels, increasing coverage that are examples. Physician has a covering pool. There's an APP float coverage. Going up a little higher, physician float or doc of the day. And then the next slide. We've described the model, a brief description, and again, bottom to top, the physician-to-physician coverage or a buddy system. And here's the pros and cons. Coverage is always physician level and by a known colleague. The patients have a feeling that someone knows them. They've seen that other physician. They know they're a colleague of their personal physician who may be away. And then as you go up higher, team coverage without an APP or team cover with an APP. So if you're at level 2 and you want to get to level 3, or you're doing something at level 3, but you want to get to a better coverage model because you're hearing that 2 or 3 doctors are leaving because they don't have any time off, and they're stressed and they're burnout, then you might look at these 7 models and think about where you are on the spectrum. And you also want to think about when you're looking for a new job, or you are mentoring someone who is beginning to look for their first position, what is the coverage? And you can look and see again this spectrum. And hopefully we'll talk more in detail about this. I'm sure there'll be lots of questions about this in the Q&A. So I'll hand it back to Dr. Jen.
Great, thank you. And then one more thing I will mention is that, you know, for if you use Epic as your EHR, there is that out of contact setting now that your practice manager or an administrator can activate on your behalf and set up the designated coverage for you so that everyone on the team knows that you are away and no one should be able to reach you directly with that out of contact. Okay, next part is enact reasonable on and off ramp policies. And this is pretty straightforward and simple, I would say, but essentially before PTO, there needs to be a clear request and approval process for PTO that everyone is on the same page about. And the lead time requirement should balance rescheduling challenges versus flexibility. So the idea is that it shouldn't just be an arbitrary number, you know, it shouldn't be 3 months lead time required just because. It should really be something that operational leaders are looking at, the numbers of, you know, what are the rescheduling needs so, you know, at this time point versus this time point, if you need to book an OR, how does that, you know, how much time does that require? It really should be operationally optimized and then minimized based on balancing those competing challenges versus the need for flexibility, and not just set some really high number that can be frustrating for physicians. And then after PTO, there should be some built-in catch-up time into the schedule templates for the first few days back, or of course it can depend on how much time was taken off. So if you took a week off, you know, maybe you should have a half day to catch up. If you took just a day or 2 off, maybe it's just an hour, but there should be some catch-up time built into the schedule templates upon return. Okay. This next part is about compensation. Again, this is a kind of a challenging and confusing issue to some people. And I think in particular, when it comes to those physicians who are, you know, productivity based or RVU based, such as myself. So you know, when we started doing this work and digging into this issue of compensation, a lot of times what I was hearing and what I've been guilty of saying myself is we have no paid vacation, right? As a productivity-based physician, we don't get paid vacation, which is actually not quite true. So when I go on vacation, I'm still getting paid in that I still get my, you know, paycheck every 2 weeks. That's not changed. So I'm still getting paid in that I do have paid vacation. So the distinction is to realize that when you hear a physician say we have no paid vacation, what they're really saying is that we have no guilt-free paid vacation in terms of RVU losses. And that's telling in itself, right? That when they're saying that, that means that they feel like they can't take time off not because they're not compensated, but because of the expectation is that there is no expectation that they're actually taking this time off, because either the organization expects them to earn the certain number of RVUs that's well beyond what they would earn if they were to take PTO, or that they expect it themselves, their family expects it, your colleagues expect it. So again, it's just I do want to differentiate compensation versus expectation. And the focus from the organizational standpoint should be changing the expectation component, because that's what is really driving the physicians themselves nuts. So let's talk more about expectation. So let's say that you get 3 to 5 weeks of this vacation plus sick days plus personal days. I kind of group those together, which I would say is pretty typical for many physicians, plus 1 week of CME time, and then holidays, all of the local, state, and federal holidays added up, give or take, will be around 2 weeks. So all of that together in total will be 6 to 8 weeks of time off per year, which then translates to 44 to 46 weeks of productive time per year. So that number, the 44 to 46 weeks, is what the expectation for productivity should be. And that could translate into the budgeting for the organization, the RVU thresholds, that physicians who are productivity based, there's typically thresholds for bonuses at either the 75th percentile or the 90th percentile. Whatever those bonus thresholds are, should be based on a realistic productivity, realistic number of RVUs for 44 to 46 weeks and not 52 weeks. And right now, I would say many organizations are basing it off of either, those national benchmarks, so like MGMA or Medicare benchmarks, which is certainly almost more than 44 to 46 weeks, right? We don't actually know what those are because that's just real data coming in. If physicians aren't really reporting their time off as part of that. So we don't know what denominator that is based on, but that is likely much more than the 44 to 46 weeks. So those are probably unrealistic numbers for most organizations, although of course that number will vary by the individual practice or organization. So again, it's just important to set realistic expectations and make sure you take all your individual variables as a practice or organization into account. Okay, again, just to expand a little bit upon what I just said. So other things for productivity-based physicians, besides the budgeting for 44 weeks only, is the imputing of RVUs. And this is more relevant for the extended leave, such as parental leave. But if you have a physician who is RVU-based going on extended leave, it is very important to impute RVUs for that leave, not for their compensation for the current year, because that should still be covered by their base salary, which is typically based on the prior year, but it protects them, of course, for the following year. So that's something that an organization should certainly build into their compensation plan. And then for salary-based, including shift-based physicians, a few key points are, of course, salary includes PTO time, so that's the vacation and CME and holidays, and also that the shift hours per month are prorated for PTO. So if you are, for example, an ER physician and expected to work 16 shifts per month, and in a certain month you take 1 week off, then during that month you should be only expected to work 12 shifts and not squeeze those 16 shifts into the 3 weeks, which sounds pretty, it sounds straightforward. It sounds like a given, but you'd be surprised how many people we talk to where this is not the case. And then consider additional compensation for a backup call. And then just a quick note on alternative compensation models. So those include panel-based compensation, quality or outcome-based compensation, and other compensation plans based on non-RVU incentives. In general, these present fewer barriers to taking PTO compared to productivity or RVU-based compensation models. However, As always, an organization should focus on removing any perceived barriers to compensation and setting achievable expectations with taking PTO. So that all goes back to listening to what your physicians are saying, and if and realizing that if there is any kind of misperceptions of how their compensation is affecting their time off, to hear that and try to fix that. So just a reminder about always listening to what your physicians are saying. Okay, and this table is just a summary of what I just talked about that is available in the toolkit itself. Okay, so last and at probably least actually in this case is the tracking of time off. So tracking always does get a little bit tricky because it is kind of a double-edged sword. Some physicians feel that tracking is very micromanaging and it's kind of demeaning to ask them to, really be entering all the time off they're taking, and feels distrustful. But then others feel that if you're not tracking something, that means you're not valuing it, right? Because if you value something, you measure it. And if you're not, then it means you don't care. So it goes both ways, but I do think it is important to do some sort of a tracking, at both the individual as well as the unit and departmental and organizational level. And as an example, for at an academic institution, there may be physicians who are more clinical and then some who are highly non-clinical, so very heavily research focused, for example. And if you're not tracking kind of consistently, you can get kind of skewed data, or if you don't have a good, robust tracking system. Because, for example, if you're a research-based physician and you only have one day of clinic per week, you might only feel the need to submit, a PTO day for that clinic day to block your clinic. For your research days, since you have so much flexibility, those may not be submitted, right? And then versus a physician who is 100% clinical, who has 5 days of clinic per week, they would have to submit all 5 days if they were taking a week off. And then when, you're looking at, if leadership were to look at these numbers, it would suggest that, the clinical physicians were taking much more time off than the research-based physicians, which was not true. So I do think it is important to have some sort of standardized practice. And of course, there's many different types of like apps and, different ways to do this. But some general principles for best practices that we came up with are, number one, to provide real-time data on time off, both at the level of the individual clinician and at the unit departmental level. And going along with that, having a way within that data where it's easy for all team members to view the remaining PTO balance, so to speak, to know how many days you have off left. And those who are not taking enough time off should be flagged, prompting managers to investigate why, and then proactively encourage that time off for the remainder of the year. EHR audit log data, so that has a lot of potential as well to give us good information. They can track access of PTR of the EHR during PTO. And again, if you find that certain clinicians are logging in and checking their inbox consistently during their time off, that should be flagged, and then someone should talk to them and investigate what the reason is behind that and try to ameliorate that. And then finally, this last point, might be a little pie in the sky, wishful thinking at this point, but using aggregate PTO taken by physicians as part of a scorecard for organizational performance. So, just as the burnout metric, like burnout rate, turnover, intent to leave, like why not add PTO on there as one of those organizational metrics? And, as Dr. Brown was mentioning earlier, that can turn into part of the recruitment strategy, right? When you're trying to recruit new physicians, you can say, look, this is how much PTO our physicians are taking, and that can be an effective recruitment as well as retention tool as well. Okay. I think that is all I have. So we can move on to the Q&A portion. So I see one that says, how can MDs not in leadership advocate for healthy PTO practices? And I do think this is the crux of the issue. It is a challenge, but also a key, the key issue, right? So we've talked about earlier how important it is for leadership to lead by example and take their PTO and really encourage it. But yeah, what can you do as a physician who is not in that position. And it is a balance because you want to advocate for yourself, but if you do it too much and it comes across as, not being a team player, and you don't want to portray, if you are working with your colleagues day in and day out, you don't want to be the one that's like, I'm taking my PTO, I'm just that's all, I'm concerned about, and, you guys deal with it. So I think the key here is really, as with anything, is communicating and working together as a group. So communicating with your colleagues, first of all, as well as with your immediate either practice manager or medical director as a group about what you're going to do, how you're going to handle this PTO. There was actually another question that came in I saw about holidays and those peak periods when the volumes are busy. And those are a challenge. Those are always going to be a challenge because the clinic, during spring break or, the 4th of July week, et cetera, those are going to be times when people want to take time off, but the clinic, if it needs to stay open, you need to come up with a solution. And that is where just getting your group together, with, for example, the practice manager, and setting out what, this just having a discussion, what needs to be covered, what's the best coverage system. We want people to feel, being just very open about what, we want people to feel like they can take PTO, but yet we have this issue of we need adequate coverage, and kind of coming together and brainstorming, if you will, solutions. I think that is something that even if you don't have a lot of support from leadership or you don't have a lot of control from the higher up levels, at least you can feel like you have some input if you just get together as a group and discuss it, and giving your physicians, that gives them some voice. And that's kind of one way that you can at least get a little bit of buy-in and a little less resentment for having to cover certain days. If everyone gets on the same page and saying, I'll cover this week, but maybe next year, I don't want to be working on this holiday, et cetera. So that's kind of my thoughts there. Dr. Brown, anything to add?
No, I'm still trying to look at the chats here. I think that you, well, there's other questions here about during peak periods when a lot of MDs want PTO, external coverage is hard to find. It's even harder to find an MD in the buddy system to cover when colleagues are away. Will it not be reasonable to ask MDs to find coverage for each other? I think that this is something that if you raise awareness of issue, have one-on-one conversations with colleagues, show them the toolkit, show them the literature, and come to some sort of consensus. We all want to provide great care. We all want to have good access. Most people who make it more transparent and have a conversation and all get together find it's fair. You might get Thanksgiving this year, but my family gets together on the Friday after Thanksgiving. And so usually if you all come together to have the conversation, it evens out pretty easily. So I think it's having dedicated time to have that conversation is important. Jill, do you want to take another one?
Yeah, let's see. So how did you land on 44 hours a week of productive time? Many organizations base productive time on 46 weeks per year. And that's true. We used 44 based on the calculations that I kind of outlined earlier, just with the 3 to 5 weeks of vacation PTO time. The lower end of productive weeks would be 44, the higher end would be 46. So it can be a range based on the specific organizations. Let's see. Thoughts about coverage for a practice that only has 2 doctors and 1 NP or less, for example. So, well, I don't know, Dr. Brown, do you, since you...
Yeah, I was in my 30 years of practice, I was at an FQHC and then a 2-person practice. And the nice thing about that is that most of your patients know your partner, so they feel comfortable. But you also have an opportunity to let the practice know or let your panel of patients know that this is when you're having your family vacation. So again, being transparent, your patients want you to have time with your family and some personal time, or go to that important meeting. They want you to get smarter. They want you to keep up with the literature. So letting them know that Dr. Jin will be out of town August 1st to 15th, generally every year, or at Thanksgiving is going to be close, so they can prepare. Okay, let me get in before then, or I can hold this question till I come back. So that is one option, but it's tough when you have only two physicians. One person has to be available to keep the lights on. Jill, do you have any other thoughts there?
I agree. I think that, nothing additional. There was a question about, so what does your PTO look like in a WRVU production model? So, I think for me personally, it is, our PTO is very, we have a lot of autonomy, as in it's not tracked super closely, which again has its pros and its cons, as I talked about. But again, there is certainly in my practice, the biggest barrier, without a doubt, is finding the coverage. Nobody wants to take time off because they don't want to find their own coverage for their EHR in basket. So that's why I really always harp on that point, is that it's not, and I can't speak for all my colleagues, all physicians, but it's usually not about the RVUs themselves at the end of the day, or the money or the paycheck. It's just the burden of burdening your colleagues. No one wants to do that. So I think that their compensation is always a factor, but I would say it's actually, for my practice, probably not the primary barrier. And I think that is true, that is the main problem with this RVU based model, is that there's such a pressure and the expectation piece on the physicians themselves.
Right. And I think that it's important to make sure that the culture is set so that everybody takes the same amount of PTO, so that one person doesn't feel like they're burdened. I've had a division chief actually say, I wish everybody was like, Dr. W. She makes the most RVUs. She exceeds her, tier 1 bonus because she never takes vacation. And again, if that's highlighted, that sets a standard for the rest of the organization. So just making sure that everybody, it's standardized, that everybody takes time off. And if you're rotating coverage, because some people are quicker to respond to a patient. So you ask that one person to cover your patients, because you know that your patients will receive a timely answer from that doctor. Well, then that doctor is asked by everybody to cover their practice when they're on vacation. That's not fair to that person. So making sure not only who's covering is tracked and that it's even is very important. One of the most interesting and I thought innovative ways to help our colleagues is somebody semi-retired, especially with telemedicine, was covering, and a retiring physician was covering for their colleagues, their younger colleagues who are out with a family trip or holiday or school break. And they had a long history, decades of experience, and they were more than happy to stay engaged, had plenty of time to talk to the patients on the phone, and it worked out very well because the retirees or the semi-retired physicians really enjoyed it. See any other questions there, Jill? Mine is...
Yeah, there's some...
Okay, here's one. I find that MDs take PTO and then sign up for extra shifts during the PTO. Does this not raise the burnout risks? Their frustration is also evident when their request for coverage is denied. Yes, and again, this is if you standardize it and
they're not allowed to do that, and everybody agrees that this is how we're going to handle and protect our PTO, then you're not going to get into these exceptions. And there will always be somebody who wants to do it a little differently. But I think that being transparent, talking about it, maybe having an expert in your HR help you get there, is extremely important. Jill, did you have one?
See, do you track sick leave? So at where I am, the only time we would track sick leave is if it was a longer term leave, like a medical leave or parental leave or short-term disability, which actually doesn't have to be that long-term, but even if it was 1 or 2 weeks of short-term disability, that would be tracked through HR. And the benefit of doing that is that we do get RVUs imputed. So even if we were to take 1 to 2 weeks of short-term disability, we theoretically could get imputed RVUs. So that's one benefit of tracking it through HR. But at a practice level, we don't differentiate sick leave from vacation. And I don't think that it has to be differentiated. I think, again, each practice can come up with their own mechanism for tracking. Some sort of tracking is important, but it can be up to the practice whether or not to differentiate the specific types of PTO. Okay, let's see. What does imputed RVUs mean? That means, so if someone is out on leave, they will take your prior productivity, they'll do a look back period of, it can range from a few months to the entire year, and see what your average RVU production per week was, and use that as an estimate as what additional RVUs we would have generated if you were working. And that process is called imputation, which just gives you credit basically for RVUs you would have earned for the organization while on vacation or while on leave. And again, that theoretically shouldn't affect your current compensation because you would still be getting a base salary, whether or not the RVUs were imputed, but it typically does affect next year's base salary for those who are RVU based.
In this we didn't get into, but this is really going to be important with extended family leave, if there's a medical issue, parental leave, and you want, again, to advocate for each other, not just for yourself. And if you have the time to get together, read some of the literature, hopefully this toolkit is just going to pique your interest. There's some really good ideas here, but planning for it and talking about it is really the key. You might start small. So if you're off for a week, blocking, or we say freezing, some empty spots for the Monday you come back that can be unfrozen on the Thursday or Friday before you return. Therefore, your practice managers aren't going to say, why are you having these, unscheduled blocks? What you're doing is providing an urgent visit. They don't need to go to the ER. They don't want to see anybody else. They can wait a few days, but they can't wait a month, and it may be a few weeks before you have an opening. So you freeze some spots, and then you unfreeze them a day or two before. And if everybody does that, then the patient gets to see the same doctor, which is, of course, better care if you have that continuity. We call that re-entry. So your schedule's full, but you're not double booked. If you have a system, or when you come back, you are double booked, that's just poor planning. That is just poor planning, and it can be avoided, and it causes such a headache. And it makes you just so nervous when you're coming back, or you spend the last 2 days of your vacation getting ready to come back because it's so difficult to do that re-entry. The other thing I think that Dr. Jill mentioned that's so important is if you have 4 weeks of vacation, put them out there. It's so much easier to block the time. And if everybody does this, block the time. And then if it shifts in 6 months, well, then the patients in that 1 week that were blocked can be moved to the other, if you change your week of vacation, you have time to, you have a space to move them. And that's what we want to do for our patients. We don't, and practice managers, we want to be very patient-centered. So there's lots of wonderful ideas here. Hopefully it'll just pique your interest. We're available for continued conversation. And then I think we have also an opportunity this fall. This will be our third innovation boot camp that Dr. Jill, Dr. Hopkins, Dr. Fogg, myself run. It's a day and a half. It's very interactive. It's limited to only 40 attendees, usually a dyad, a physician seeing patients, and their practice manager or their non-clinical partner. And we will introduce PTO. We will highlight getting rid of stupid stuff, gross, which is another toolkit, because there's a tremendous amount of waste in our day. And we can highlight also reducing regulatory burden. So often we're overinterpreting much of what we do in the day, and it's unnecessary. We can get those hours back in the day to give better patient care and get home on time without taking our charts home and our EHR home. So I think we're at time. Dr. Jen, any closing comments?
No, thank you everyone for being here today.
Thank you for your time. Hopefully we'll see you in September.